Welcome to the Currents of Public Health webinar series presented by the School of Public Health at Georgia State University. My name is Brian Greer, and I'm the Director of Development for the School of Public Health. The goal of this series is to explore relevant public health topics with members of our community. Today's topic is biostatistics and infectious disease modeling in public health. Our guest is Dr. Alexander Kirpich, who is an assistant professor in the Department of Population Health Sciences in the School of Public Health. Dr. Kirpich received his undergraduate degree in mathematics from Belarusian State University, followed by a master's degree in statistics and a PhD in biostatistics, both from the University of Florida. He is a biostatistician with expertise in infectious disease statistical modeling in areas of cholera, dengue, HIV, anthrax, and others, epidemiology, and bioinformatics. He also has worked on transmission models of cholera and HIV in collaboration with medical doctors and epidemiologists. He has broader interests and goals in application of statistical methods to public health and biomedical research questions and policies to address statistical challenges, such as missing data, asymptomatic infections, underreporting, and noise during data acquisition. Today's webinar will be guided by three general questions. What are you doing? Why is it important? And how can we get involved? A quick note, if you have a question at any point during our conversation, please feel free to type it in the Q&A box and we will try our best to answer. So let's begin. Dr. Kirpich, welcome to the webinar. Please tell us about your research, what you're doing, and why it's important.
Hi, Brian. Thank you for organizing. First of all, I want to thank you for organizing all this. It's a pleasure for me to give a short introduction of what I'm doing. I believe it will be helpful for a broader community, as well as it will be helpful for our students. So, well, first of all, I'm actually sitting in this building on my fake background. So it's always cool to point people to there. Anyway, I'm sitting on the 4th floor. Anyway, so all right, so this is the way the topic is going to be organized. In the beginning, I'll say a few words about biostatistics. Why is it even called biostatistics? I'll tell a couple of words about the perception of statistics in the broader community as a discipline and as a field of science, as well as I'll talk about direct applications of statistics to infectious diseases. And then I'll give a couple of research problems that my student and I worked in the past couple of years. And I hope it will kind of narrow down the scope of what I've been doing for the past 2 years, as well as it gives people a perception of what statistics is and how it's related to public health. This is a very broad talk. That's why we will go briefly over main concepts. Okay, so let's begin. A few words about biostatistics. The best question, or the first question, is why is it even called biostatistics? Well, it seems like a simple answer, but it seems like a simple question, but the answer is not necessarily very simple. So the formal definition is like this. Biostatistics is a field of statistics that specifically deals with the study of biology, health, medicine, and the environment. So it is basically application of statistics to health sciences and to biological sciences. It also involves some decision making. For example, clinical trials and similar studies, when based on the available public health data or based on the available environmental data, public health officials or government has to make decisions based on the knowledge obtained from biostatistical analysis. But it's obviously not everything. It is used to design experiment, collect the data analysis, interpret results, draw conclusions. So it's also what it says is that statistics and biostatistics are also used to conduct experiments and to set up studies, to plan controlled experiments. When you have a control group and you can actually compare the control versus your intervention or treatment. Also, biostatistics is used to study disease patterns. What does this even mean? When health data comes in, it has to be analyzed and conclusions has to be drawn, especially from surveillance data, but not only surveillance data. That's what biostatistics is used for. And this field is also very important because it is very closely related to public health decisions. I believe everybody has seen that recently because of COVID-19 pandemic, when decisions based on data analysis were paramount and they had to be done quickly. Well, a couple of words about myself. Traditionally, there are statistics departments in schools and biostatistics departments in schools. What's the difference? Statistics departments are usually located within the colleges of liberal arts and sciences, engineering, and they focus more on theory. And sometimes they're located in the School of Agriculture as well as in the business schools. At the same time, biostatistics departments are typically located at the schools of public health, at the schools of public health professions, and at medical schools. So they're directly geared towards applications to public health. That's why I'm actually here, because I'm at the School of Public Health, of course. All right, so I hope it opened this broad veil of what's going on in the field. But what about perception? Well, it's tricky. When I tell people that I work with biostatistics for a living and I'm a biostatistician, it's usually not perceived very well. What is going on there? Well, people typically tell me that they don't like the subject, and it's usually very softened wording. Typically, people say that they hate statistics and they took one class in college and it was absolutely horrible. I hear it all the time. And the question is, why does it not happen? That's a reasonable question, like why? The question is simple, but the answer might not as simple as we want it to be. Why so? Well, can be multiple reasons, first of all. I will just list some of them. And if some of you don't like statistics at the moment, but I hope you will like in the end of the talk, you can potentially recognize some of those bullet points. So the first one is a perceived difficulty. It can be complex, especially if you have limited mathematical background, and if everything is condensed into a simple class or a single class, it's really hard to understand everything, because if you have a 2-semester sequence, and if you're not working in this field, this can be indeed very challenging. So difficulty can be obviously one of the reasons. The second one can be prior negative experiences. For example, you might have taken statistical classes in your high school as AP classes, or you might have taken it in your undergraduate degree as a calculus substitute, things like that. And in this case, the experience might not have been as good as you wanted it to be. And here you go, this is the result. Lack of relevance. As I said, since usually most people who are not working in this field, they tend to take only one class or 2 classes. Everything is crammed into that, and it's really hard to see a connection to real life and to real life problems. You basically see, oh, if you see this data, you do this approach. If you see this data, you do this approach. But since you're given like 20 different approaches, it's really hard to wrap your mind around those. What about other reasons? Well, that's a very common one. A lot of people have fear of numbers and mathematics. It's just because everybody has a different expertise, and some people don't like that area. And statistics is obviously heavily involved in that, especially in probability theory, especially in matrix algebra, ordinary differential equations, stochastic processes, all that. So it involves some advanced mathematical concepts, and if you're not really in that field, then it might sound and it might look burdensome. Also complex jargon and terminology. When I started to learn it myself, statistics uses a lot of words which are well understood within the field, but not as well understood outside the field. I think this is pretty common, not only in statistics, but in any field. But I think it just adds a cherry on the top of the pie, especially if your perception is biased from the beginning. Challenges in interpretation. This again goes to the fact that many people only take a 2-semester sequence, and the interpretation is given to them and they can use it, but because of time limitations, we typically don't have enough time to dig deeper into the concepts of each specific interpretation. That's why that can be also a challenge, and that can also be a problem. And the last one is less specific, but it's still pretty much there. It's a perception of boredom. So it's perceived as a very dry subject. You see some formulas, you plug something somewhere, you get some result, you analyze the data, and it seems like a very tedious and monotonous thing unless you work in that discipline. That's why it also affects the overall perception of the general society. So all those things definitely affect perception, but at the same time, I want to overcome some of those difficulties, and I want to show how those concepts are applied to real life problems, especially in the field of public health. All right, so a couple of words about myself. As Brian said, I'm doing infectious disease modeling. In particular, I worked a lot on COVID-19, and how is biostatistics helping there? I believe COVID-19 is really a good example because it allows us to analyze what's going on and to predict the pandemics. So the first thing that biostatistics can be used, was used, and will be used for will be statistical modeling on infectious disease spread. we can start from simple susceptible, infected, recovered models when you actually count how many people are in each of those groups, and you can predict that over time. And you can go into more advanced models, which allows you to model infectious disease dynamic over time. So basically, prediction, estimation, and this gives you an idea how your epidemic going to behave in the nearby future. This is especially helpful for public health policies. What about some other application? Spatial and temporal analysis. This is pretty straightforward. Obviously, the disease spread is not uniform geographically and temporally. For example, you get outbreaks of COVID-19 here and there. Not only COVID-19, of course, HIV outbreaks in certain geographic areas due to drug abuse or some other issues. The same thing with time component. You can get epidemics of flu in the fall of every year, but at the same time, the flu is pretty slow in the summer, stuff like that. So temporal components and spatial components are very important, and temporal and spatial analysis can play a crucial role in understanding of what is going on with your pandemic or epidemic, or basically when outbreaks. A data analysis and surveillance. I think monitoring is a key thing to prevention. For example, it can be some historic data of a certain disease, and it can be monitored very carefully. And if the number of new cases, the incidence grows severely, obviously, this should be addressed somehow. And monitoring helps to kind of raise a flag and to see what is going on there. It can start from just simple visual inspections of the graphs and tables, but of course it can be more advanced statistical modeling involved, which will be closely related to the first bullet point, to prediction. Risk assessment and control strategies. Also, regardless of how many cases you have, many or not that many, it's always good to evaluate the potential risks and possible costs to healthcare system, possible burden for healthcare system, and similar related issues. So statistics, biostatistics, and statistics can be widely used for that topic as well. Policy and decision support. Well, it's pretty straightforward. After you analyze some data, after a biostatistician analyzes some data, provides summaries, those summaries are given to public health officials, and it obviously affects the policies. For example, there was a policy to do two-dose regimen for COVID-19 vaccine. Obviously, it came from a trial, from the analysis of the trial data. And everything else, like mask mandates, everything essentially comes from some analysis that you are doing as a statistician, a biostatistician. Every decision is typically based on the previous analysis, which is done by us. So this bullet point is a brief summary. It actually says that biostatistics is a backbone of infectious disease modeling, not necessarily for respiratory diseases, but for any other diseases such as sexually transmitted or chronic diseases. It doesn't really matter. Careful analysis is paramount for pretty much any of those bullet points. All right, so I hope I gave you a brief introduction, which gave you some overview. What is going on? Why is it called biostatistics? Why is it not perceived great by general community sometimes? And how is it related to infectious disease modeling? But I have not shown you any specific examples. So right now I'll show you a couple of examples where I directly applied biostatistics to real-life problems. And the first example is COVID-19 excess mortality in Ukraine in 2020-2021. This was studied right before the war. Obviously, when the war started, things changed quite a bit because it was a huge migration of people. But in the period right before, it was a good case study where it was possible to monitor what is going on with the general population and how the pandemic affects the overall mortality in the region. A couple of words to describe the background and to provide you motivation for this study. Since the beginning of this pandemic, some regions of the world were affected more or less by the pandemic at different time periods, as well as some were studied and monitored more carefully than the others. If just to remind, Ukraine is the second largest European country by area after Russia, and it's the seventh largest country by population in Europe. So it's a pretty big region. And still, there has been little attention given to Ukraine because the majority of the studies were focused on Western Europe, because more money is given to research there and related issues. And Ukraine has introduced strict non-pharmaceutical interventions such as social distancing, mask mandates, all those things from the beginning of pandemic in March 2020. The implementation and the strictness of those measures were not monitored rigorously. Even though on the paper they had those restrictions, the implementations were not monitored or penalized as heavily as in some other European countries. And the other concern was that COVID-19 mass vaccinations was only announced on February 1st, 2021, and started a few weeks later, which is typically, well, which was much later than in most of other European countries. So it was a delay in vaccination. On top of that, before the war in February 2022, only about 34% of Ukrainian populations were fully vaccinated. So there was a widespread hesitancy against the vaccine, and because of rumors and other reasons. So even though the vaccine became available, even later, it was still available. People were pretty reluctant to use it and to get vaccinated. So all this provides a good setup, not good, but like a meaningful setup for evaluation of what was going on in terms of the mortality. And I believe the setup is clear, but what about the analysis? What about the results? How do you deal with those problems? I will show you now. So typically excess mortality is compared between regions of the world in terms of standardized p-scores. So you essentially standardize the score based on the expected mortality for that given region. In this case, you can compare those p-scores across different countries. For example, Ukraine versus Poland, Ukraine versus Belarus, Ukraine versus Russia, and some other countries. And to Ukrainian credit, this country government provided very good reporting, and that's why this analysis was possible. So now we can see that the quality of data directly affects what kind of analysis you can perform. So there are two main approaches for that, non-parametric scores and parametric scores, and the difference is the expected mortality is either evaluated as historic averages or the expected mortality is evaluated from some statistical model. So what else is interesting here? And those scores are usually converted to percentages for easy interpretation. So if I show you the figure, I hope it will clarify things up. And if you have a look at the bottom graph, the green line is the observed mortality in Ukraine. And this red line right here, it is the start of the pandemic, the first detected case, but the first official detected case and confirmed in the laboratory. What about blue line on the back? The blue line is the expected mortality. How is it computed? For example, based on the 5 years that precede the mortality, for the five years that precede the pandemic start, we had historic mortality for every month of the year. So we can take average of those and interpolate them right here. This will provide us the idea how the mortality should be in the future. And then after the pandemic start, you can easily compare it with the observed mortality. And if you convert this excess into p-scores, you can easily see that the burden of the pandemic was the highest in November 2021, and it was 80% above what was expected. So, and it also confirms that there were 3 waves of the pandemic, and they were in the late 2020, sorry, in early 2021, and in the end of 2021. And the reporting stopped in December because of the war and related conditions. This is the similar result from a parametric model. Those yellow dots, they come as a prediction from a parametric statistical model. And as you can see, you can easily observe the numbers from the data, which are much higher than what is expected. And then after this is converted to p-scores, you can still see similar numbers in terms of the excess. All that provides good summaries, but what about numbers? Well, you can directly take the difference between observed and expected. Again, the expected come from statistical modeling and observed come from the data. And you can see that results across different models, they're comparable, and the excess mortality was from 14,000 to 32,000 during year 2020. And the excess in the year 2020 was 30% in November, 33% in December. Again, it's different across different models, but the results are somewhat similar. For 2021, the numbers are much worse. The excess deaths for the entire 2021 was about 130,000, depending on the parameterization. And as I said, for November, this score right here was 80% higher, between 74 and 82% higher, depending on the model that was used. So as you see, it seems like you can see directly the application of all those models. You can quantify the excess mortality, you can quantify the burden, you can quantify what time of the year was the heaviest, the pandemic had the heaviest effect on the general society and on the overall mortality, as well as you can quantify how many people have passed away, of the estimated number of people that passed away in comparison to the situation when there would be no pandemic. All right, so the second study I want to focus on is also interesting, but it's close to home to the United States, and it talks about Legionnaires' disease in Washington, D.C., and also provide a motivation for that study. And the municipality of Washington, D.C. was selected because of the reason. What was the reason? Usually, Legionella is a reportable disease, but it's reported over huge geographic units. And that's why it's really hard to study anything. Also this because over large geographic units, it's really hard to see signal. But Washington, D.C. is a small geographic unit, and it allows to perform such a study. Study area is located in Northeast Mid-Atlantic region, which already had a lot of history of Legionella in the past decades. This study area is geographically homogeneous and located within the same climatic zone and has precise meteorological data. This data has been collected from Washington Airport. And also, which is also very important, Legionella is believed to be driven by water, and there is only one source of water in Washington, D.C., which is Potomac River. And the nice thing is that Washington, D.C. maintains very detailed record of water measurements for the region since 2001 until 2019, both from the surface water as well as from treatment plants that are used in the area. So there are two treatment plants, but the results across them were comparable, and they both maintain very detailed records. And again, this was a reportable disease, and the results were extracted from the CDC. So I hope the setup looks pretty clear, but what about the analysis and the summaries? First of all, let's have a look at the raw data. This is the raw data and the reported number of cases from year 2001 until year 2019. At this point, it doesn't bring us much information. It's very dry. Also, you can see that there is a large number of cases here in October 2020, 2019. Can be also error in reporting, possibly. And as you see, the raw data do not tell you much. You can do some basic summaries, mean standard deviations, but it's not enough. What if you do some graphs? Does that help? Yes, it does help a little. First of all, this is the reported incidence for the same time period, and those are box and whiskers plots, some basic statistical summaries that you can think of. And even from those, you can see that the majority of cases are happening in the second half of the year, somewhere between August and November, which also corresponds to the biology of the disease, I believe. All right, between the years, the heterogeneity is huge. For example, there were no cases in 2013, almost no case in 2013, 2015, but the number of cases in other years was pretty high. Well, when you run some statistical model, things becomes more interesting and things become more clear. On the left column, A, B, C, D, I still have raw data. For example, incidence, temperature, precipitation, and wind speed. All that records have been extracted from the airport weather station. And then if you do some statistical modeling here, I'm not going into details, of course, but you can start from simple Poisson model, zero inflated models, and go into advanced topics. You can predict the cases, and you can see what factors affect your presence and absence of cases. And again, due to time restrictions, I'm not going into that, but you can see what's going on with Legionella and what are the patterns and what factors may affect it. So based on our model, we figured out that LD incidence had majority of cases from June to December, second half of the year. Temperature increase was associated with Legionella, which is obviously in agreement with everything that have been published so far in the literature. Surface water, increased concentration of manganese, iron, and strontium were positively associated. And for aluminum and orthophosphate were negatively associated with all the incidents. And we also analyzed treatment water from the plants. treatment plants, and we looked at the total organic carbon, aluminum, barium, chlorine, and we investigated whether they are associated with LD incidents. And some results were also not conclusive because the data are sparse. As you have seen, we have a lot of zeros. So this also brings us to the fact that the raw data, which is located like this, and which is located here, and which is not very intuitive, after you summarize it visually, and after you do some modeling, it gives you way more information, and you're able to identify potential compounds which are associated with LD incidents. So you can dig deeper into the topic and maybe do some lab experiments. At this point, I'll stop because I'm running over time, and I want to again thank Brian for organizing all this and the School of Public Health for their continued support.
Yeah, thank you, Dr. Kirpich. So some quick follow-up questions. I'm just curious, if there's a way for those on the webinar today or in the community to get involved with your research, how would they best do that?
Well, with me or with biostatistics? That's a good question.
Yeah.
I think if you're interested in any topic, regardless it's working with me or with any other professor in biostatistics, the first thing to do is to look at the papers of that person, see what you're interested in that type of research, see what kind of conference this person attends, read the person's portfolio. That will be a very good start. If you read the paper, it provides usually up to 80 to 90% of information of what this person is doing. So looking at my papers and maybe presentations like this will be the best start, I think.
And I'm just wondering as well, what do you see as the biggest challenge in the field of biostatistics today?
Well, that's a good question. I think it's very important to realize that any model that we are using, it's a very simplified version of the reality. And this simplified version of the reality has limitations. And the biggest limitation, especially for the field of public health, is the data quality. When we are talking about computer science or some Google searches, the data are usually perfect. You have very little missing data, everything is there. But when we are talking about infectious diseases, underreporting, misreporting, typos are widespread, unfortunately, because a lot of humans are involved into collecting this data and they work really hard. The same thing is applied for clinical trials or any other trials that are involved with individuals. So data quality is probably the biggest challenge. And when me or anybody else as a biostatistician is looking at the data, we should always be aware of it and try to mitigate the effects of this.
So a follow-up to that would be, for the general public, as we see in the media, different studies and different things like that we come across, do you have any suggestions to help us understand what we're reading or what we're looking at? Because I know sometimes data can be just pulled out and thrown in front of us. I mean, do you have a way for us to decipher kind of what we're trying to understand or being shown?
Well, it's complicated. It's a very thorough question, obviously, and the answer, it requires like a really long and thorough answer. But the short one will be, well, you always have to be critical. You should always look at the sources of that data. You should always think where this information came from. If you can look at the original paper, you can try to dig deeper, because the original paper or the original research material might not necessarily be interpreted correctly. It's not because of anybody who wrote this blog wanted to do it on purpose. It might be because just some things is really hard to grasp if you read it briefly. So the first thing is to look at the source of the information. That will be number one suggestion from me personally. And the second thing is to think critically about everything and try to look at the alternative research in the same field. If it's I think any paper that is written so far, if it's confirmed by multiple independent studies, that definitely brings you more confidence in the result rather than one study. One study creates a precedent, but you always have to independently confirm the findings. There are situations when you cannot, or you have to make decisions based on just paper or just one paper. I understand that. But ideally, you should always be critical, look at the sources, and confirm the findings through multiple studies. Basically, repetition of the reproducibility, so-called.
Yeah. So what advice, there might be some students on this webinar today or some students that find this webinar after the fact. What are some advices that you would give to students interested in pursuing a career in biostatistics?
Sorry, my lights is going down. Let me turn it on 1 second.
Oh.
Well, his lights are back. Okay, that's a good question. So first of all, if you're really interested in the field, the first thing you should do, you should attend as many seminars as you can, look in the papers, look at the material. If you want to prepare yourself better, there are a lot of classes that are required for formal statistical training, but they will not hurt even if you want less formal statistical training, such as matrix algebra, calculus, of course, differential equations, probability theory. All those will definitely prepare you to work in that field. But the first thing to do, again, is to figure out whether you like it or not. And again, looking at the papers, looking at the seminars, will give you an idea in that direction.
And we did have a question from the audience back on the data that you had, the Ukrainian data
Yes.
from the pandemic. The question was why the annual cyclicality of the deaths in Ukraine prior to the pandemic. They noticed that it was lower in September and higher in January every year. Is there any reason for that you can explain?
What slide we're talking about? One sec.
I'm not
This
sure.
prior to pandemic, lower September, higher in January every year. Okay, so usually, okay, there was a question why there is a periodicity in this data before the pandemic. Okay, I think I got the question. So if you look at the red line, everything after the red line was a distortion in the system. It was a pandemic. But if you look prior to pandemic, mortality is always cyclic. And the majority of cases come in the fall because I feel like not the fall, maybe like December, because it's colder, less vitamins, I assume. It's just my speculations. But that has been the case, which I observed all the time. Most cases happen, most deaths happen usually January, early spring, stuff like that. So that's not a new thing for Ukraine. And my explanation, Alex's explanation, is because of the colder weather, because more influenzas and related infections, which can be vulnerable for high-risk groups, like much older people and people who have compromised immune systems, stuff like that. So it's not a new thing. It's not a new thing, and I think it's also climate-related. It might not be the case as much in Miami, but definitely in Ukraine and in colder climates where you have seasonality, that is the case.
Gotcha. Well, thank you for answering that. So my final question is, where do you see your research in 3 to 5 years? So that could either be, in general, biostatistics or where the research is going, or just what you're interested in doing in 3 to 5 years.
That's another question that will probably require another 50 minutes. But in brief, I want to keep doing what I'm doing as the first thing. But also, COVID-19 showed that molecular epidemiology will play more and more important role. Will keep playing the important role, and the significance of that role will increase because the amount of genetic data and sequencing data will increase. So I'll keep digging into that field. I'm working on it a little bit, and I'm learning more. So I want to do more bioinformatics, more genomic epidemiology, transmission models based on the connection between the viral sequences or bacterial sequences.
Gotcha. Well, again, thank you for presenting. And I want to thank all of you who are attending today's Currents of Public Health webinar. And I also want to thank you, Dr. Kirpich, for providing this informative conversation. It's been really good. In closing, the School of Public Health at Georgia State University is one of the most diverse schools of public health in the nation, offering a Bachelor of Science in Public Health and a graduate certificate, a Master of Public Health degree in 6 concentrations, a PhD degree in 4 public health areas of knowledge, and a Doctor of Public Health degree. The faculty and students conduct research in complex public health challenges facing cities across the globe. Our work is often carried out in partnership with communities, the residents, and community-based organizations committed to health equity. If you'd like more information about our programs and how to support the work of the school and our students, please visit publichealth.gsu.edu. Thank you again to Dr. Kirpich, and thank you all for attending. This is the last Currents Public Health webinar in the fall semester. Please join us again for the next webinar series in the spring. We'll have some more information about that soon, and we'll see you next time. Take care.